while we're waiting for the next panel, I just want to talk a little bit about how fascinating for me and most of the feedback I got at lunch this day has been from the varying perspectives that we've able to bring to make the unseen providers seen from various different angles. And I want to especially take this opportunity to thank Nan Torrey, wherever you are, right next to me, for all the work that she's done in putting this meeting together. We could not have happened without Nan. And to thank my staff, Marie Leaf, Max Cuddy, Philippe Levy, Matthew Bekele, and Julia Kaiser from Burness Communications for their efforts, and to thank Mary Darby from Burness Communications for all the work that she did in getting those papers to you that you had to read before this, as well as Ben Milder from Burness for all of his ongoing help in helping us think through all of these challenging issues. And that's thank you to all, and especially to Nan. With that, we're going to try and do some closing comments. I think the order of operations is Keith. I need a fifth chair. Could someone put a fifth chair on the stage? Keith, you sit right there. Right. Can I have that fifth chair, please, Sarah? Keith, you sit right where you're sitting. Is Dr. Clark here? No. Not yet. So we'll save a chair for Wesley, and then Ed, and then Greg, if you would go at the end, that would be great. So let me go ahead and introduce our trying to make sense out of the day. Dr. Barton is the medical director of Cochs. He has a long history of expertise in correctional health care, having worked at the Alameda County Jail, which is the Santa Rita Jail, for several years. He's board certified in internal medicine and acupuncture and holds a certificate in HIV medicine. And at Cochs, we're very fortunate to have a jail experienced physician as part of our team. Dr. Clark, I'm sure most of you know, he is the director of the Center for Behavioral Statistics and Quality. Right now, he was historically the director for Center for Substance Abuse. Ed Harrison is the president of the National Commission on Correctional Health Care. He's been there, Ed, over 30 years? NCCHC has been around, not you, NCCHC has been around for over 30 years now?
Since the early 80s, right?
Yep. And they have been the leading provider of standards and independent accreditation of correctional health services. And finally, I want to introduce Greg Warren, the president and CEO of Baltimore Substance Abuse Services. And I think the format for this is I'd like to sort of ask each of you guys a springboard question, if I could, to do that. And so I guess, Keith, what I'd like to ask you is we spent a lot of time today talking about routinization and the relationship between electronic systems and predictability and routinization. I know part of the work that you've been doing has been trying to decrease variability between jails and looking at best practices as a way to do that. Could you talk a little bit about some of that work?
Thank you. Well, as many speakers have noted today, jails are frequently chaotic environments. And in addition to that, there's a great deal of variability between jails in terms of their size, their staffing patterns, the level of information technology that they might be utilizing, treatment protocols that are utilized in the jail for various conditions, the therapeutic resources. Some jails might have an have an infirmary, and some jails will not. And there are also variations in budget constraints for the different counties that the jails operate under. So to make the best use of health information exchange, there needs to be some attention to reducing the variability. And one of my projects at Cochs has been directed at developing some best practice proposals for healthcare in jails. These proposals would hopefully decrease gaps in the care in the jails, improve predictability, and routinize healthcare screening, mental health screening, connectivity of care and follow-up of care after people leave jails, and improve access to treatment in the jails. These steps are necessary to promote smooth information exchange between jails and communities. And I think these are themes that other panelists are likely to represent as well.
So we have best practices in prisons. We really have not had best practices, clinical practices in jails.
That's my understanding, and I think that's a reflection of the high level of variability between jails and the reluctance to impose that variability on jails although as you've been saying, health information exchange shines a bright light on what happens in jails, and that in turn increases the value of having more routinization.
Right, and best clinical practices. I think the other thing that, Keith, you haven't mentioned is part of you've been doing this is trying to take some best practices in the community and to the extent that you can adopt them to jails, and that hasn't been the easiest fit.
Well, again, the staffing levels and also just the intensity of activity in the jails is an impediment. You know, if you have 25 people arrested on the evening shift, unless you're in New York and can afford to have a 4-hour intake process, the pressure is to get people in and out.
Yeah, quite a different thing. Ed, you've been working on developing a different perspective on routinization. It's on the outcome side. So if part of NCC being an accrediting agency, it's my understanding that what you've been doing is trying to develop a whole series of healthcare systems that have outcome measures to them. And could you talk a little about that and how that fits with some of the efforts of NCQA, the National Commission on Quality Assurance, in terms of their outcome measure efforts?
Sure. I think everyone recognizes that electronic health records are coming to corrections someday. Question is how long it's going to take, what form it's going to take, and what are the incentives for a correctional system to develop an EHR and participate in health information exchanges, and we've been discussing that throughout the day. From our perspective, and it's true we are an accrediting body, but we're about quality improvement, and our interest, well, our belief is that we can't wait for an EHR to solve problems or health information exchange. Something we haven't talked about much today at all, if at all, for those outside of corrections, is a recognition of the deep and ever-present presence of the threat of lawsuits. Risk management is an integral part to managing a correctional office, a sheriff's office, a department. So there are 3 ways to get things going, or there's maybe a bunch of ways, but 3 ways to point out. One is you could pass a law. If the law says something has to happen, the correctional agency, the sheriff's office is going to follow the law. The other way is to dangle the carrot of dollars. And if there are federal dollars attached to it, and this is going to be a way to supplement or augment or replace dollars from the county level, that's going to be greatly appreciated. The third is value. If there's a perceived or evidenced value in initiating an activity, then people are going to do it. And in the context of not waiting for an EHR to come into existence, we formulated for a number of reasons this idea of establishing CORDS, which stands for Correctional Health Outcomes Resource and Data Set. The idea being that it would provide benchmarking, which would be of value to the providers, either at the corporate level, the sheriff's office, or the county commissioners, whoever is asking for those data sets, to use in measuring just where we are. I talked about lawsuits earlier, and as many of you know, the state of California had long-standing lawsuits and health outcomes issues and ended up going into receivership with its prison system because of bad outcomes. And one of the things that the receiver's office tried to do was say, well, really, how bad is it in California compared to other states? Well, there was no way to compare. There was no standardization of outcomes measures for corrections. And that happened to dovetail with a report NCCHC done on the health status of soon-to-be-released inmates, talking about the burden of chronic disease and looking at outcomes in corrections. So we've established this program, which is developing quality measures, performance outcomes measures, based on NQF-approved measures from NCQA or others, but adapted as necessary for corrections. And the people who are participating at this stage of the program are developing the measures, as I say, and submitting data that gets reported back to them anonymously without any patient identifiable information, and used for quality improvement purposes. This, getting people to agree on the standard measures and used to reporting and sharing data in a comfortable way, we think is paving the way or making it easier to get to that point should health reform pass in its current status and the regulations come down and other things come into place where people are going to have to report or be encouraged to report.
So it's interesting. I hear both you and Keith talking about routinization and the role of healthcare technology in both paving the way and creating the opportunity for and creating a feedback loop in terms of routinization, and jail is a very chaotic environment. Hi, Wesley. It's okay, no problem. I think that the other part of the challenge of routinization, Wesley, it's perfect timing because I'm just my lead-in.
I was covering for you.
The other part of routinization, that's the challenge in this, has been that behavioral health care has been left out of meaningful use. And that we all know that within the jail environment, the number one issue that we confront are folks with behavioral health disorders. And if meaningful use, part of what Judy was talking about this morning, if meaningful use of standards are the vehicle through which we're going to figure out how we create routinization on a national level, and we know that the jail population is primarily a behavioral health population, then Dr. Clark, we're hoping you could guide us through this forest.
Welcome.
That's a clear sort of culture gap or dissonance between these two perspectives, which I suspect you are knee-deep in alligators in almost every day.
Well, actually, we are actually. As it turns out, there are a host of entities that are seeking access to substance abuse treatment records. And I think that's cause for caution. It's not just the criminal justice system, but it is also a lot of the public service entities working in the community, housing authorities, TANF, right, food safety authorities, child welfare authorities, et cetera. In one way, the jails actually have an easier approach in the criminal justice system because there are special exemptions to the criminal justice system or for the criminal justice system and negotiating the exchange of information. You have the person, you can easily get their permission to their consent, as it were, put quotes around the word consent. But the real question with electronic health records is who else has access to the information and how widely is it spread. Accountable care organizations, the question is, well, what do you do with the information? Because it's supposed to be a feedback loop. And 42 CFR Part 2 doesn't support feedback loops outside of consent. So, but again, the criminal justice system has a special exemption. The Congress felt that the criminal justice system should have that exemption. So the real issue, as people have discussed in the past, is having the systems in place where that information can be exchanged. Because there's a wide diversity of substance abuse treatment programs. So those are medication-oriented or medically oriented, and then there are those that are non-medically oriented that have a different set of information. As you know, as you pointed out, we weren't in the meaningful use criteria, so developing software that deals with the behavioral health phenomenon is going to be a touch-and-go issue. There are over 100 vendors and roughly 25 vendors who have meaningful use 1 certification, but most don't actually deal with the full spectrum of behavioral health issues that would concern The criminal justice system, you want to know whether someone's got a medical problem. You want to know whether they have HIV. You might want to know whether they have a history of violence or psychosis, et cetera. And it's not just 42 CFR Part 2 that we're dealing with. We have many jurisdictions that also classify mental health information as protected, and then there's genetic information that's protected. So there are a wide range of other issues associated with exchanging information. But both the criminal justice system and the substance abuse treatment systems have anemic electronic health records. So even if the rules permitted it, from a practical point of view, the resources are not there to leverage that exchange of information.
So what I'm hearing you say is we have sort of a resource issue, which is not a small one, in terms of doing this, and yet we have the most expensive, what tend to be one of the more expensive sets of patients that are in our nation's jails, that have behavioral health disorders, and yet we haven't made the resource investment to hook them into the system. That's a little dissonant, don't you think?
Well, I think, obviously we're in this time of resource shortages, and I think people have put a pause on this concern, so it's really useful to have this issue kept on the front burner, or at least in people's awareness, because there's this tendency when money is tight to bypass some of the most vulnerable, particularly associated with the criminal justice system, because of the underlying assumption that, of, quote, just desserts.
Right, and I guess Ben Butler this morning mentioned David Mancuso's data, which shows that investing in substance abuse treatment saves both healthcare and criminal justice costs. And I think it's important for those of you who are not familiar with that data, if you go to the library on the Cochs webpage, you will find David Mancuso's data there. I want to encourage you to take a look at it, because I think this sort of frames the complexity of this discussion we're having at a high public policy level, which is we know that these services save money on both the healthcare and the criminal justice side. We don't know yet how to bring them into health information technology, and I think that's part of the challenge. Greg, I asked you to join because of all the folks who are in this audience, I think you wear the most unique set of hats. So I want to just describe the hats that I know about that you wear. You're on the state HIE board in the state of Maryland. You've worked within a correctional system for many years. You've worked being an addiction counselor in a community-based setting, and you now run a consortium of 17, is that my number right, agencies? How many agencies do you have? Well, whatever it is, a certain number of agencies in Baltimore Substance Abuse Services in which you coordinate and which you've been, in effect, building a linkage system out to the correctional health system through an electronic medical record system. And you looked briefly in one of your questions, but if you could tease out for us, I think you've got probably more street experience and understanding. We're all public policy nerds at different levels. Dr. Barton is the closest one of us, but I sucked him out of providing care in a jail and put him into a policy hat, which he grumbles about every now and then. But you're probably the closest one to trying to make all sense out of all this and all your different hats. Would you try and summarize for everybody where we go with this?
Sure. So just to clarify one point, the agency I run, my agency is the local substance abuse authority for Baltimore City, which is the largest city in Maryland and which gets 40% of all the public substance abuse dollars in the state of Maryland. We don't provide any direct services ourselves, but we fund 50 to 60 prevention, treatment, recovery programs, whether it be in hospitals like Johns Hopkins or very small drug-free outpatient programs or in elementary schools, that kind of thing. So that's what I do. So 20 years ago when I got involved in addiction counseling, not having been addicted, I asked myself this profound question: why are they here to see me? And then, why do they want to keep coming to see me? That was the second question. And the third question is, when asked by my next door neighbor, why is it that I'm in this business and how do I know it works, right? And so it's that mindset that I've looked at substance abuse treatment, whether it's in drug-free outpatient programs, working with homeless, HIV, in the correctional settings and so forth. So what is it that they're coming to see us for? And they're there because they have a motivational moment. Criminal justice arrest, DSS, school, ER, something is driving them. Why is it that they want to keep coming to see you? Is because what I used to tell clinicians I supervised, you're only as good as your Rolodex. In other words, how you're able to connect that particular patient to a service that they perceive as valuable. All right? And so then, how do I explain it to my next door neighbor what I do, and does this really work? And they basically want to know two things. Is my grandmother going to get robbed by the drug addict down the street? And am I going to have to keep paying more taxes to take care of uninsured folks who are doing terrible things? Right? And so that's a very profound question. Now, the thing is an electronic health record system and the partnership between corrections and community programs actually has a profound way of helping all three of those issues. All right? Because the first is I will be able, as a clinician, to treat the entire person. They're there for a substance abuse problem, but if I have a consent, I can connect them to homeless services. I can connect them to entitlement benefits. I can connect them to the Goodwill agency down the street that's going to give them clothes. You know, I can connect them to this much larger world and explain the benefits of that connection through an electronic health record system. I thought the video this morning was terrific, and Steve, I also want to appreciate your leadership in putting this together. I think it's very invigorating to come. And that video, I think, really captured, even though it's based on Camden, Baltimore City's challenge. It looks exactly like Camden if you walk around the streets of Baltimore. And there was a profound moment in that video that, I don't know if many of you noticed, there was a patient that was rocking back and forth, and the clinician said to the patient, so are you going to make those phone calls? Now, I don't know about you, but many of my patients in the past didn't have the ability to pick up a phone and make those phone calls. It takes the clinician with a therapeutic rapport connecting that person to another entity, and the electronic health record system can be that vehicle. So backing up to why I first got interested in electronic health records is first to answer these sort of profound questions. The second thing is with healthcare reform coming in 2014, I knew that very small substance abuse programs needed to learn how to bill managed care and need an electronic billing system to be able to do it. That was the first thing. The second reason is that to maintain clinical and cultural diversity in a city where a community substance abuse program fits the needs of its community. And the way I describe it is, I shop at my neighborhood convenience store. When I buy cakes, I go to a particular store that's within 2 miles of my house. We shop within the neighborhoods that we live in. We get sick within the neighborhoods we live in. We need to get healthy within the neighborhoods we live in. And we need substance abuse programs that reflect the clinical and cultural diversity of every neighborhood in our city. And without an electronic health record system, these very small programs spread across the areas where you work and live are not going to be able to survive. And so I felt that it was my responsibility and my agency to help provide intelligence to programs in terms of being able to purchase an electronic health record system. I had already seen small programs make bad decisions, purchase an electronic health record system, find out it was a lemon, and spent, in one case, $250,000, to replace it. The remarkable thing was the executive director kept her job, and the program didn't go under as a result of that bad decision. And so, programs on the community side don't have IT expertise and are set up for making really bad decisions. And so I felt the need to reach out and hold focus groups with providers to figure out exactly what they needed. The second part that is sort of a key understanding to this is that public safety and community programs both have a burden of unfair expectations. So when I was in public safety, our task was to rehabilitate people. And the Baltimore Sun headline would read, "Inmate just released commits another crime," right? And it's an unfair expectation, yet it's an expectation that's put on corrections. The same thing goes for substance abuse and behavioral health programs in that, how come you're not cured? You've been there 28 days. Shouldn't you be cured? And so both of us have this expectation of an unfair burden that I think is just really it's a travesty. The second part is substance abuse programs, because of bifurcated funding, because of sort of being the sons of somatic care, are not connected to somatic care. And so we have argued that substance abuse programs should be a part of the public health system. And I think that's a case we still need to try to argue. The second part of the coin is correctional systems are a part of the public health system. And I challenge you to go talk to any warden, any department level secretary of a prison system, and they will say they're a part of the public health system. Inmates, as Ed addressed, or partially addressed, they're the only group in this country that have a constitutional right to health care. And so when I was in corrections, we were making a tremendous investment in terms of assessment and treatment, and I thought it was a shame that we couldn't communicate that information to anybody in the outside world. What would be the benefit in terms of reducing criminogenic thinking and behavior if we were able to pass it on? I think it would have a profound impact, on our society. The other part of the equation that both corrections and community programs, I think, share an equal burden is that we have to make the families of these patients healthier, and we have to make the communities in which they're returning healthier. And so with better effective community supervision, I think, and the use of electronic health record systems with a DPP agent, parole and probation agent, in partnership with a case manager at a behavioral health organization, in partnership with a PCP, that kind of combination can leverage incredible motivation for change and produce significant cost savings. In Maryland, we have encountered a great deal of support for trying to create this consortium, which very simply is we are, on a voluntary basis, programs will be buying into an electronic health record system, pay the user fee. I'm going to have local foundations pay for all of the implementation and training costs, and then it would be sustaining simply by programs paying, a monthly hosting fee. But in a state budget, the two biggest cost drivers in a state budget are health care and incarceration. And so when you want to get a state's attention in terms of communicating to an HIE, and saying to the HIE, behavioral health wants to be at the table and be connected, they are very open to that once you point out the fact of the public health crisis that behavioral health and criminal justice, that nexus creates, for at least for the state of Maryland that I can personally speak to.
So, Greg, I have a question. I really respect the work that you've been doing. We've been trying to do our best to Cochs to help you out to the extent that we can. What I puzzle about is how much of this is your charismatic leadership and your very distinct role in crosswalking the public safety and community system. That you have a idiosyncratic situation where there was a new inmate management system bought that happened to have an EMR as part of it. You've been able to leverage that EMR out into the community system. Is that scalable in other communities, or is that an N of one because Greg Warren's who Greg Warren is?
So that's a great question. So let me tell you some of the things that I've encountered. First, my agency is a 501c3. We're an independent agency. We get direct state funding. I have a 25-member board. The City Health Commissioner of Baltimore is the chair of my board. I have everyone from the police commissioner, Department of Housing, various state and city politicians, on the city council president, they're all on my board. So it's taken so let me back up. Public safety, they want to improve recidivism. Since I work there, they do have a level of trust with me that I understand their issues and concerns, and that's helped a lot. The second part of it is convincing everybody on the outside that, okay, if you get this EHR, then won't public safety somehow be the big brother and start data mining and figuring out, all of this and that? And that is a legitimate public perception concern. And so that's also something that I've had to be very conscious of. One of the things that is critical about making this corrections to community program consortium work is public safety knows that I will be their champion on the community side, that people will be contracting with Baltimore substance abuse programs, will be contracting with Baltimore substance abuse systems, and not with corrections. That if corrections decides to dump this EHR, go back to the dark ages, we will still exist as an electronic health record consortium. So it takes an outside champion to help communicate to programs. If you're the warden and want to reach out and say, I really want to communicate better with you, I think that will really not go well. You know, and that you need somebody on the community side to be your champion.
That's a really helpful perspective, because what I'm hearing you say are several things. That in terms of scalability, there's got to be a level of trust that's a two-way street. That community folks have to trust that public safety isn't going to mine their data, because that undercuts their mission. But public safety has to trust that their interests are going to be represented at the table. And I think that it's a very unique, and I'm hoping, as you know, we're hoping at Cochs, that it's a scalable model that you're putting in place, where I'm having basically a fully linked system between jail and the community with a behavioral health focus, with no federal dollars from high tech, because it's not MU, right? It's all being done on a local basis of trying to build it, with philanthropy propping it up. And it represents, from where we sit, about as far as anybody's gone in really thinking through what's the role of electronics in doing that. I think what I've heard from you over the past several months, Greg, is consent has been an issue, but it sounds to me like you're working that one out. It's a fair thing to say. It started out as a big issue, but I think you're most of the way there. That money has been less of an issue than you thought it would be. I think that's fair to say, because the community benefit is so high and so obvious to everyone that you've been able to bring in philanthropic partners to understand how it's in the public interest to sort of follow your lead in doing this. And that the underlying posit, going back to what we were talking about this morning, is that treating an underlying behavioral health disorder will result in less criminal conduct. And that resulting less criminal conduct will result in lower recidivism, and that ultimately that's the financial driver that makes the system work. And that to some extent, you're engaged in a sort of a real-world experiment to do that. There are a couple of risks that I want to put out on the table, some of which you and I have talked about. One is that for the first time, you will be able to look inside the black box of the substance abuse agencies that you fund. That you will be actually able to see what services they're providing, their relative level of efficacy, who lowers recidivism, who keeps people in recovery, and who doesn't. And I don't think we've had nationally, Wesley, you can correct me if I'm wrong, but I don't think we've nationally had this kind of natural experiment where I have what's in effect a fiscal intermediary being able to look into the black box and measure efficacy of all of the different styles of substance use disorder treatment that are happening in Baltimore. I think that's an exciting thing to happen, but I think it represents a community risk, and I don't want to understate it. Am I right, Wesley? We really haven't had that anywhere else?
You're right, but you also need to recognize that there are other dynamics going on. Accountable care organizations are also dealing with the issue of the multiple placements of an individual in terms of, because they're responsible for things like housing and food and et cetera. So human services agencies are working with healthcare agencies, and part of the thrust is indeed this holistic approach of managing an individual. And with the ACA, people who are vulnerable but who haven't committed crimes and who are eligible as single adults within the income range will be able to get health care services. But as I pointed out, there is a move afoot to discuss how do we involve housing and how do we involve employment and how do we involve food safety and child welfare, et cetera. I think what you have in Baltimore is a movement to anticipate that, but we do know some of the incentive awards, people are looking at vulnerable populations as a way of addressing these issues. Naturally, we'll have to wait and see how things unfold over the next couple of months.
That's correct.
If things come out in the right way, this whole process will accelerate, and then there will be more interest. We are trying to encourage our grantees, whether they are reentry programs or drug courts, to adopt EHR. We can't require that at this point in time, but it's clear that the community has to recognize the utility, as Baltimore has, of having access to electronic health records. But you're just not communicating with the jails, you are communicating with a wide range of entities. The question of consent management becomes a critical question, and we believe that if you work with the patient, consent follows. But sometimes people want to treat the chart and not the patient.
Right.
So that's the limitation of that. So we have people saying, we don't want to be bothered with consent. We should have unlimited access to a person's information. And I think that's frightening to the community, particularly on both sides,
right,
which has less to do with someone's involvement in the criminal justice system and more to do with this sort of big brother phenomenon where all your information is at other people's ready disposal.
And the public housing issues and all
public
that.
housing, et cetera. Right. So those are issues that we are struggling with.
Great. We have time for a few questions. We got to wait for my folks to bring up the microphones. I know Don has one up here. Could you identify yourself, Don?
I'm Don Murray with the National Association of Counties. One issue that we're very concerned about, and we're hopeful the new legislation will be carried out, but that we build on what we know is exciting. 2,400 counties in the United States have less than 50,000 population. There's a huge shortage of trained personnel. Like, we only have 1,000 counties that have at least one psychiatrist in the country. Most of them are on Park Avenue. I mean, if you walk on Park Avenue, there's about 7 each block. And then we only have at least 600 counties where they have one endodontist. So if you need a root canal, you're in big trouble. But what has intrigued me for many years is the Minnesota Community Corrections Act. It's aimed at trying to get the whole state together, rural and urban. So the vast majority of the United States is rural. There's the geographics of it. And unless we can encourage multi-county approaches, and that's what Minnesota does. They have a population threshold of 30,000. You can't get money from the state unless you bring in your neighboring counties. And they set up a multi-county system. It's not a building. They're not talking, they don't equate the correction system as a building. It's a system. And you can carve up that system into pieces. And the way it was conceived in my favorite consortium, Olmsted, Dodge, and Fillmore. Olmsted has the Mayo Clinic. So Olmsted claims they're in charge of health care. Dodge and Fillmore, 2 rural counties, they do other things. One thing that's crucial, we know that there are only about 400 counties that have pretrial service programs. So the initial assessment is very deficient in the country. The Justice Department estimates that counties could save $8 billion if they simply set up a sophisticated pretrial system. So as a result, 62% of the people in jail are there not necessarily because they're dangerous, but mostly because they're too poor to post bail.
Mike Jacobson's data bit is on any given night, there are 650,000 Americans that will spend the night behind bail to failure to have $500 to post bail.
So I would hope, and Steve, I want to congratulate you on picking such fine panelists throughout this program, but that the rural issue has to be addressed. I mean, the first time the federal government even counted the number of jails was in 1970.
Right.
You remember that?
Yeah.
When it made the front page of the
Yeah.
New York Times. It was such a revelation. Revelation.
I appreciate that, and as I mentioned in response to Hugh's question, we specifically have been trying to focus on the rural issue, and we were sad that Dr. Campolo couldn't be here today to talk to some of his experiences. I have time for two other questions.
Well, I just want to point out with regard to HIT,
go ahead.
both the Office of the National Coordinator of Health Information Technology below the Secretary's level and the Secretary's level are interested in fostering health information technology as a way of facilitating access to care both for substance abuse and mental health and physical health for people in rural areas. So HIT, especially with the advent of increased broadband, which clearly for many rural communities is still an issue, that we'll be able to do this. Now that's going to create some jurisdictional issues in terms of the criminal justice system, in terms of moving information, because a person, especially in near borders, may be receiving clinical assessment from one jurisdiction while they are lodged in another jurisdiction.
But we have models for that. We have a kind of multi-county agreements. Yeah.
So that's an important thing to keep in mind. We are concerned about health care in rural communities, and we're developing models at least to foster that and using multiple personnels like physician assistants, nurse practitioners, but who have consultation capability through webcams, the internet.
Right. And as we heard in our last panel, telemedicine.
Telemedicine.
Greg?
So I appreciate your comment about the difference between a rural setting and an urban one. The statistics I just want to share with you can pertain to both, but the role of a HIT, I think, can be very helpful for rural settings, particularly because there was a study done in Baltimore that showed, the average age of somebody in substance abuse treatment is 42. The age of first arrest was 13.8. The age of first crime was 13.8. Age of first arrest was 16.5. Age of first incarceration was 20.1. So in other words, people are touching the criminal justice system a vast amount of times before they ever enter substance abuse treatment. And so if pretrial did have an effective HIT system that could effectively divert people to whatever resources are in that community, I think there would be a significant cost savings, and we're just wasting that motivational moment.
So it's very interesting you say that. We're actually in the middle of looking at how do you match a pretrial services program with a diversion to treatment program, and how do you scale those kinds of things, and what's the role of Medicaid in changing that paradigm? I think we all would be in agreement that that's sort of the next frontier in trying to think this through. Questions? Yeah, go ahead. Could you identify yourself, please?
I think addressing the rural area and things like telemedicine and other types of technology processes like that is that our attempts to make that technology work in order to address the rural problem has been solved based on having a record, an electronic record. Without the electronic record, we could not make telemedicine and other types of collaborative technologies work. And so that's why it's important that we deploy the electronic records as broadly as we possibly can, because without that chart, those providers that provide and clinicians that provide consultation can't do that without that documented historical information that the
And
chart
that's, again,
contains.
another form of routinization, that by being able to create these records that don't have those hundreds of paper records that you saw in the film, we create a frame that folks can fit in. I think there was a question on this side. Is that correct? Great. Well, with that, I want to thank this panel.